Good afternoon. My name is Charles Wilson, and I supervise the Community Health Education Division at the Washtenaw County Health Department. I want to take this opportunity to thank everyone for tuning in to today's webinar. As a result of the COVID-19 pandemic, this series was transitioned from an in-person conference to a virtual one. The transition to a virtual series would not have been possible without Gabrielle Slimcare at the Washtenaw County Medical Society. So a big shout out to her and the important work that the Medical Society is doing in our county. Funding for this series is provided by the Marijuana Regulatory Agency of the Department of Licensing and Regulatory Affairs. In addition to the information shared by our speakers, you can find more information on our website at washtenaw.org/marijuana or on social media at Washtenaw Public Health. These website locations will be placed in the chat box as well. Speaking of the chat box, please feel free to post questions in the chat at any time during this webinar. This webinar is being shared via Facebook Live and is being recorded. The recording will be available on our Facebook website for later viewing. Additionally, the slides used during today's webinar will also be available on the website. And at this time, I'm going to turn it over to Gabrielle to introduce our speaker.
Thank you very much, Charles. The Medical Society is very proud to be partnering with the Health Department. Again, thank you for all of your hard work and your teams. I have the pleasure of introducing our speaker this afternoon. Dr. Mark Weiner received his undergraduate degree at the University of Michigan. He earned his medical degree at Cornell University Medical College in New York City. He completed his internship and residency in internal medicine at Northwestern University, McGraw Medical Campus in Chicago. He is board certified in internal medicine and addiction medicine. Dr. Weiner is located in Ann Arbor, practicing full-time addiction medicine and pain management. At St. Joseph Mercy Hospital, he is the medical director of substance use disorders, the section head of addiction medicine, program director for the Addiction Fellowship, and medical director of IHA Recovery Medicine. Within the American Society of Addiction Medicine, he serves as the chair of the Maintenance of Certification Committee for the ASAM Medical Education Council and is the immediate past chair of the planning committee for the course, Pain and Addiction, Common Threads. He is an author and editor for the recently published American Society of Addiction Medicine Handbook on Pain and Addiction. Dr. Weiner is the immediate past chair of the Board of Trustees of Dawn Farm Treatment Centers in Ann Arbor. I am turning it over to you, Dr. Weiner.
Thank you, Gabrielle. Thank you, Washtenaw County Medical Society and Washtenaw County Health Department. That was a wonderful introduction. I couldn't have written it any better. I'm going to start sharing my slides, and hopefully you guys will see this right here. And if anyone is not seeing a slide right now, please let me know. It's an honor to be here. Also presenting, it's an honor for him and it's an honor for you and all of us. Dr. Brendan Sullivan is the only addiction medicine fellow in the state of Michigan. There is only one every year, and he is it, and he is here. And he's going to be presenting part of this, this lecture. First part is just a disclosure. I am not accepting money from Big Pharma or Big Cannabis or Big anybody. I did not use cannabis today. Any weird comments are my own, naturally. So the objective of the talk today is to walk out of the talk and not be afraid to have a really good, meaningful discussion with a patient or a friend or even a family member about marijuana. It's a really difficult conversation to have if you're talking to patients and you're in healthcare and you're a healthcare provider. I'm assuming mostly people here at the lecture have some interaction with healthcare. And by the end of this, you should develop some strategies to help you through that difficult conversation, both taking inventory of how it feels to be a provider having that discussion and to consider where the questions from the patient are coming from and their mental state around cannabis in today's sort of health system. So in order to kind of get ready for the talk, you have to be able at times to imagine you're in the room with the patient and the topic of cannabis has come up. I'll use cannabis and marijuana interchangeably during the talk. And it can come up in a number of ways, and we'll talk about that in a minute. And at some point, so it's important to imagine that you are a patient with chronic pain, and that will be important. You'll see later on. A little disclaimer just about me and this talk is that there is some science out there regarding cannabis, but what it's all over the place. But what you're going to get today is focused primarily on my clinical experience with patients who have addiction, patients who have chronic pain, and consulting work I do with primary care doctors who ask me questions about how to deal with their patients who are using cannabis, or the question comes up, and it comes up quite a bit. Clearly, there's a strong selection bias for the patients I see. The chronic pain patients particularly have failed mostly all traditional pain management techniques. I mean, just think about it. Someone, usually a pain specialist, has referred the patient to an addiction specialist to figure out what's going on. And I've developed this sort of niche profession of taking care of patients with chronic pain and sorting things out. And also, just a disclaimer, I have this, I like shocking patients by being unexpectedly open and understanding, no matter what comes up. And I encourage you as healthcare providers to do the same. It's fun. So the conversation starts in a number of different ways. And it can start simply as the patient asking the doctor or healthcare provider or nurse or social worker, do you think I should try medical marijuana? Everybody's talking about it. Or, usually sometimes after the fact, the patient says, I've been using marijuana for my pain. What do you think about that? Of course, we also run into, if your patients are treated with chronic pain medications, often they get drug screens, and patients who have addiction get drug screens. The topic could come up when the patient responds to you. What do you mean my drug screen says I'm smoking marijuana? And that starts the conversation. It can start in a number of ways. So I'm going to present a case. This is a real case, and I've kept all the information that would identify this person out of it for anonymity purposes. So this is a 48-year-old man who comes to me with chronic neck and back pain that he's had for 19 years after a really bad car accident and multiple back surgeries that have failed. When I originally met him, he was on very high doses of opiate medications for pain and multiple sedatives, powerful sedatives. He was wheelchair bound. His labs showed he had vitamin D deficiency. Urine tox was negative except for the medications he was prescribed. We, in my practice, and this is not part of today's talk, but we transitioned him off opiates to buprenorphine and off the sedatives. And he was doing really, really well, maintained on a really normal dose of buprenorphine medication for pain. And he was able to do these things that made his life better. He was able to interact with his son, which was very gratifying. But then suddenly his pain began to worsen in 2012, and we couldn't figure out why. He was doing really well for multiple years. We tried increasing the medication. Nothing seemed to work. And eventually, as we do when things aren't going well in medicine, we start from scratch. We get all the labs redone. And lo and behold, his urine toxicology shows THC, which is an indicator for the use of cannabis or marijuana, greater than 1,000. Now, this is sort of a dated slide. Greater than 1,000 was the limit of lab testing equipment back in 2012. They actually had to make new lab equipment because cannabis is so potent now that goes up to 1,500. However, now a lot of people I test are greater than 1,500, so it didn't fix the problem. Any case, so he said he'd been using cannabis to help him with his pain, he thought. But his pain was getting worse. And we talked about stopping the marijuana. And he said, sure, no problem. Well, he didn't stop. It does happen. And sometimes people don't listen to their doctors. And his urine tox was the same. He later told us there was more information. Not only was he having trouble stopping using cannabis, he was also growing cannabis because that was part of the Michigan medical marijuana program. He was a caregiver. So this became part of the situation for this particular patient. And this happens. So let's stop for a second and just think, why are these conversations difficult? When patients bring up cannabis in the exam room, what are we feeling? What's happening? And I would say, after thinking about this and talking to lots of different doctors, the emotion that is under all of this is fear. For the physician or the healthcare provider, there's a lot of fears. One is the fear that the patient is doing harm to themselves, and I don't want a patient to harm themselves. Number two is the patient is asking me questions about things I don't know about. That causes fear and frustration for a physician. There's the fear that you don't want to look, if you're a physician, you don't want to look like you're a prude. You don't want to look like you're not open to new ideas. And they're like, oh, all you doctors are the same. There's a lot going on that causes fear. And fear doesn't help us make good decisions. The patient is also afraid of being judged. The patient is afraid he or she might be treated differently. So there's fear on both ends of that equation. And trust me, the fear doesn't help come to a good outcome in that particular conversation. Part mixed in with the fear, expectations of a doctor, of what he or she thinks he or she should be. And the patient has expectations about the doctor-patient relationship that often doesn't include cannabis. So ultimately, you get this conflict of ideas and ideals. You want to be your healthcare provider. You want to be an advocate for the patient who might say this is helping him, but you don't know how to answer the question. And you end up with this other question, which is, what does it really mean to be a good healthcare provider in this situation? We're going to get to that. So to start the conversation off initially, most importantly, is be aware of your own emotions as the healthcare provider, because this can come up and this could push you in the wrong direction, and you can have a lot going on. And try to relax. And it is okay, though, to be honest about your feelings in certain ways, or have the patient discuss their feelings about what's going on. I think it is perfectly reasonable and is actually a good technique to use the term, as you're a physician or healthcare provider, I don't feel comfortable prescribing opiates if you're using cannabis. First of all, no one can argue with your comfort level. It just is your comfort level. But it also clarifies something that is about just you, the patient, and the situation. I really feel that if healthcare providers bring up other issues like, well, the government doesn't want me to let you do this, or I'm going to get fired, I'm going to lose my license, if those things are taking other entities into the conversation, really do not make the outcome a good one at the end. So the other question to ask ourselves is, why are we having this talk? Why am I even talking about cannabis? Why are we learning about cannabis? Cannabis is, now a big deal. It's on the paper. It's $1 billion industry. Why? Why are we talking about it? We're not having conversations where patients are saying, hey, doc, I'm kind of sluggish in the morning. How much methamphetamine should I use? Or when I get home from work, I'm tired, I should use some more cocaine. That's not really being brought up in the conversations we're having today. But cannabis is here. Why? Why is it here? Well, the reason that cannabis got brought into this discussion, or these discussions regarding medical care, usually are for conditions or patients where the conventional medications are not effective or meeting the expectations. So people are frustrated. They're missing out on what they feel is a way to a quality of life that their goal is. Medications, conventional medications, can be too expensive as an excuse, I hear often, but I'll tell you that using regular cannabis is not cheap for people at this point. We're having this conversation because our patients are being exposed to lots of information about cannabis, promoting cannabis. Mostly, that's a lot of the information. There's some information about the harms. It seems to some patients that some medical professionals accept cannabis as a good option. So that's why it comes into the conversation. There's a lot of weak science in both directions, so not a lot of people know what the right answer is. So that makes it something to ask your doctor about. So when I look at the chronic pain patient, again, there are other indications of why people use cannabis, and we won't get into those, otherwise this would be a really long talk, way beyond our hour limitation. But for the chronic pain patients, again, they're frustrated. They need us as healthcare providers to have compassionate discussions about their pain and discuss all the things that can be utilized: pain psychology, yoga, tai chi, supplements. We should be able to discuss marijuana. This is not meaning that we are recommending it, but we need to be able to have a discussion about it. And I think that the other direction, which is to be dismissive, dictatorial, pedantic, or prejudiced in some way about cannabis in that conversation doesn't help. The patient walks away not getting any more information. You didn't get any more information about why the patient even wanted to use cannabis in the first place. And that's where this talk leads you to, being able to have that type of conversation. So again, just to consider you're the patient for a moment. I know we're good at being healthcare providers, but think about the patient. Patients are frustrated. They have family and friends who are saying, you know, my friend uses cannabis and he's fine, or it helps him with his back pain, or he's able to, you know, run a marathon after being in a wheelchair. You know, there's all kinds of stories. There's lots of advertisements. I don't want to mention any particular, but there are billboards all over the place. I just was on vacation up north and just driving on the highway. You see all kinds of cannabis dispensary advertisements, thousands of dollars of advertising going on there. People have used cannabis in the past, maybe recreationally. By the way, cannabis today is probably 30 times more potent than it was around Woodstock in the 70s or even the 80s. And you know, hopefully by the end of this talk, you know, just the patient's frustrated because they don't know what you are about to know. And you're going to know some things that might help you have a meaningful conversation with your patient. So why are we? Then the other question is just why are we, the medical doctors and the medical professionals and social workers and other people even talking about cannabis? How did we get caught up in all this? Well, the people who are promoting cannabis were really smart, and they kind of used the medical entryway of saying we need to allow people to use cannabis for compassionate reasons, and we'll talk about that in a moment. But we did get voter-approved medical marijuana programs. These were not doctor-approved. Doctors were not allowed involved in that legislation. It was just legislators and voters. Doctors are needed to certify or endorse use in the medical marijuana program, not so much in the not at all in the recreational use. There are potential positive effects of cannabinoids. Now, cannabinoids are the substances in cannabis, but it's not the same thing as saying there's known positive effects of using cannabis, because there's a lot of different chemicals, and Dr. Sullivan will talk about that in a few minutes. But there's a good side to this. We get to be brought into the conversation as healthcare providers and educate the patients. Now, you might say educate them about what? Maybe you don't know how to educate them. Hopefully you'll learn something in the next 20 minutes. So basically, and not to go into too much detail here, the ideals of what it is to be a physician, as an addiction physician. I have concerns about the use of cannabis because it's an addictive substance. I also manage pain in patients who have failed everything. And some patients actually say, well, you know, I've used it a few times and it's improving my quality of life. This makes it hard for me, probably for you as healthcare providers, having this conversation. So, and just to overstate the obvious, if we take inventory on the subject of medical marijuana, it's really frustrating for us to have this conversation. But I think we can turn this into a golden moment for both us and develop a relationship with the patient that's better, and for the patient by educating them. It's frustrating for us because the pro-marijuana advocacy groups are using compassion as sort of a manipulation to kind of get us to say everything's okay, and we don't really know. We don't know what to say. But if we let the frustration over this of this take over, we lose really important opportunities to help patients. As a side point, the medical marijuana part was never really medical, and it never had the things that you need to have to be part of the medical system. There weren't medical professionals who said it was safe and effective. There were initially no requirement for ongoing doctor-patient relationships. Normally medicine involves a prescription that's controlled in the amount of substance by a licensed physician. These things never happened in the medical marijuana programs. So the general guidelines to having this conversation is, first, as the healthcare provider, take a deep breath of room air. Just to be clear. Don't panic. Let the patient talk and listen carefully, just as you would if it was any other medical question that was being asked. Try not to be judgmental, dismissive, and no matter what they say, don't roll your eyes. It's not helpful. I've learned this the hard way. So what are you listening for? Well, it's important when a patient is frustrated or having a problem to find out why they're using the substance, why they're using cannabis. But additionally, cannabis use causes problems in these areas. So we're looking for changes in the patient's function. Did they have a decline that led them to stimulate them to use the cannabis? Did their pain get worse? Were they having trouble sleeping and thought cannabis would help? Is their sleep getting worse or better since they've started using cannabis or regularly started using it? Frequently, it does get worse. Has their mood changed? Often this is a good question, not only for the patient, but for the family member who's present at the visit. Is their nausea getting better? Is their nausea getting worse? We'll find out in a little while how cannabis can make nausea worse over time. Are they using it for appetite issues? What's the cause of their appetite problem? Has anyone investigated an appetite issue? Is the patient, say, mildly obese and telling you that they have appetite problems? What's going on here? This is important. These are important things to listen for. Is the motivation changing? Are there memory issues? And how are social interactions before and after cannabis use? These are things you want to assess and document in your chart to give you some direction on how to handle these conversations and how to direct patients in the right way. So patients do not like to be treated as idiots, criminals, deviants, children, or addicts, which, by the way, I treat addicts very well, so I don't know if that's really a bad thing. But patients respond really well to being treated with respect and compassion, no matter what the topic is. So the first thing to do is simply clarify to the patient that you're going to talk about your medical opinion, that you're not talking about the legal, moral, political, or spiritual aspects of marijuana. I will often say something along these lines. I'm not a lawyer, I'm not a policeman, politician, priest, rabbi, or your spiritual leader. You're paying me to be your medical consultant, so I'm going to give you my medical opinion. That's it. Now, what's the problem here? Well, if you're in the healthcare profession, you may not have a medical opinion about cannabis. So how do you get one? How do you get a medical opinion? Well, since there's not a ton of reading you could do, and there's not a lot of science out there, and the studies that are done are sometimes contradictory or inconclusive, you have to ask the experts. So who are the experts? Well, these guys. Remember these guys? I guess can't raise hands here if you know who's who. Yeah, this is when I was young. This is where I learned about cannabis from Cheech and Chong and all the movies. You can learn about cannabis watching CNN. Dr. Sanjay Gupta did 2 really good programs on cannabis. And despite what people think, I don't think the conclusion was that Dr. Gupta is recommending everyone consume raw cannabis. He talked a lot about cannabinoids. So in order to get one, the medical experts you have today are right in front of you, myself and Dr. Sullivan. And at this point of the talk, I'm going to turn it over to Dr. Brendan Sullivan, the esteemed only addiction medicine fellow in the state of Michigan, to take over for quite a bit. So I'm going to stop sharing.
All right. Thank you, Dr. Weiner. And I will take a moment here to pull up the slides. Okay. So we talked about the actual history of cannabis or marijuana. It dates back to 2700 BC when the Chinese Emperor Shennong used the marijuana tea for treatment of gout, rheumatism, and malaria. And there were multiple instances throughout the centuries, even millennia, about the use for treatment of medical issues. In 1000 BC, there's a Hindu description of cannabis used for the pain of childbirth, insomnia, and headaches. In 500, there was describing the burning of the hemp for intoxication and religious trance. And then in 200 AD, cannabis was described in the Chinese pharmacopoeia. And recently, up until about 1965 is when the THC molecule was actually identified. Now let's take a break here and think about understanding the following terms. And we've used cannabis and marijuana interchangeably. Cannabis is the name of the plant, Cannabis sativa. Cannabinoids are the known substances within the cannabis plant that acts on the endocannabinoid system. The endocannabinoid system is the body's intrinsic system, and the body does have 2 endocannabinoids that regularly act on the system. And we'll go in a little bit more detail into that later. THC is the main mood-altering substance, and as Dr. Weiner alluded to, the percentage of THC is variable among the preparations of cannabis, and it has increased over the last 20, 30 years. So these are the terms that to be aware of, and these are the terms that when we talk, a lot of it just gets built in and brought into the understanding of the umbrella of cannabis, but there are some benefits to the actual cannabinoids. However, there's at least 85 known cannabinoids in the cannabis plant, so there's multiple substances going on or acting in play. In terms of the general medical opinion about cannabinoids, the opinion of the modern medicine is encouraging and sympathetic towards the research and development of the cannabinoid-based medicines. And there have been a couple examples where substances and molecules have been synthesized and used for medical purposes, which we'll get into. And these are specifically to the cannabinoids, the molecules that act on the endocannabinoid system. This is a quote from one of the ASAM conferences about 10 years ago now, back when we actually had in-person conferences. But with regard to what we know about the endocannabinoid system and pain, anyone who chooses to smoke the raw product, cannabis, is performing an extraordinary experiment in polypharmacy. And this just speaks to the fact that not only are there at least 85 cannabinoids within the cannabis plant, but there's even approximately upwards of 500 chemicals that the body can inhale. In terms of the actual structure of the cannabinoids, these are just a few examples. Delta-9 THC, again, is the main mood-altering substance, and that structure is up there in the upper left. The ones in the bottom left and the bottom middle, anandamide and 2-arachidonyl glycerol, or 2-AG as it's also known, are 2 of the body's synthesized endocannabinoids that affect the system. This is just a picture of the chemical structure, THC, and it's spinning around there, and that's about all pretty much say on that. But it has been synthesized and really known for about the last 55 years. In terms of the actual research into the endocannabinoid system, or again, the body's intrinsic system, in 1990, there was a group that was able to clone the CB1 receptor. And then in 1993, there was a group that cloned the CB2 receptor. And those are the 2 known receptors that are at play in terms of the endocannabinoid system. And we'll talk a little bit about where those receptors are. In 1992, a group identified the first endocannabinoid, the anandamide. And 1995 came along the second endocannabinoid, and that was 2-AG. In 1994, there was a CB1 receptor antagonist, rimonabant, which was also developed, and it has been used in terms of, it has been studied as an anti-obesity medication, but it also has a lot of preclinical research effects. So a lot of research was performed within a fairly short span between 1990 and 1995 within this endocannabinoid system. And this research is not very old. If we look at the concentrations of the CB1 receptors, they are present throughout the brain, and they're not specific to the brain. There are CB1 receptors also located in the liver, in the kidneys, but the ones that it's highly expressed in is the brain. The medulla, there's effects on nausea, vomiting in the chemoreceptor trigger zone. The cerebellum has effects on movement, as well as the basal ganglia. The cerebral cortex affects higher cognitive function. Hypothalamus affects appetite. Hippocampus affects learning, memory, and stress. And the spinal cord is the main receptor for the peripheral sensation, including pain. Here's a picture of the presynaptic neuron and the postsynaptic neuron. And the CB1 receptor is located on the presynaptic neuron. And remember, both endocannabinoids and cannabinoids can affect this receptor. So the exogenous cannabinoids, for example, THC, affects this receptor. The endogenous cannabinoids, or the 2-AG or anandamide, are synthesized in the postsynaptic neuron, travel back to the presynaptic neuron, and inhibit activity of neurotransmitter release from the presynaptic neuron to the postsynaptic neuron. And there is a low level or homeostatic activity that is constantly going on. THC binds to the CB1 receptor and has about a 20% affinity. Synthetic cannabinoids, such as they're known as K2 or spice, can even impact up to 100%, have 100% affinity. And so there's a highly variable in terms of this affinity of the exogenous cannabinoids themselves. Now we take a look at the relationship between cannabinoids or cannabis and addiction. The timing of the first use, we have studied and we know that as the younger someone is exposed to cannabis, they are at an increased risk of developing a dependence. This is seen as adolescents are 2 to 4 times as likely as adults. And even we see that the brain is not fully matured until age 25, maybe even into the late 20s. There is an increased risk of dependence from the 18 to 29-year-old group compared to the 30 to 44-year-old group when compared to the greater than 45-year-old group. So if you have someone in their 18 to 29 age range, they are about 7 times as likely to develop symptoms of dependence compared to someone who picks up their first joint or their first hit of cannabis if they're older than 45. About 9% of those who experiment ultimately become dependent. And there's a interest in the utilization of cannabis in terms of the priming of for later addiction. So there has been some interest or research or commenting that cannabis is labeled as a, quote, gateway drug. There's really no little scientific research in terms of that. We like to think about more as a priming drug. And so there's the main system that is affected by the disease of addiction is the dopamine system, or the system of the feeling of getting high. And cannabis affects that regulation, especially if it's used at an early age. It also may enhance responses to other drugs such as alcohol, cocaine, or heroin. Then we take a look at cannabinoids and the relationship with pain. There are endocannabinoid receptors in the nerve endings, the dorsal root ganglia, the spinal cord, and the thalamus. The endocannabinoids do have anti-pain effects. So there's the 2-AG and the anandamide do have anti-pain effects. Now, the CB1 and CDV2 antagonists that were synthesized around the early 90s, they block these anti-pain effects. So this really leads to that the endocannabinoid system is highly regulated and heavily involved in the pain sensation pathway. So there really is unimpeachable evidence of cannabinoids aiding in pain relief. Again, different than cannabis, which again, very important to know that to make that distinction. A study was performed in 2010, and they took a look at 23 patients who had neuropathic pain. A low number of patients, but it was an excellent, in terms of excellent study in terms of the methods. Patients were given very specific amounts of cannabis. They had very specific instructions on how to inhale, and they were given all the same pipe to inhale. And if they, depending on the potency of THC, this is ranges from 0 to 9.4%. There is some improvement in pain intensity across, in terms of if they inhale it. Now, the THC percentage of this study population, I think, is very much different than the population that currently uses it. And as you increase your THC percentage of the amount that you're inhaling, there is a higher risk of psychiatric effects. And so in that 9.4 percentage group, or the patients who inhaled the THC, the 9.4 percentage, they had increased lack of concentration, paranoia, racing thoughts, fidgety fingers. So the conversation point here with having the patients is there is probably a sweet spot of pain benefit, possibly for cannabis based on this study. But if one starts to get high, or if they have some of the mood altering effects of cannabis, they probably overshot that mark. We look at cannabis in palliative care. Dronabinol, which is a cannabinoid, that is synthesized and isolated. It is indicated for chemotherapy-induced nausea and vomiting. Due to the lack of compelling evidence, cannabis, the plant itself, is no longer recommended for chemotherapy-induced nausea. And when we last polled the hospice patients in Washtenaw County, there were about 4 requests for a medical marijuana card in about 1,200 patients. A lot of times we treat patients who have significant coronary artery disease or heart disease, and so there are CB1 receptors located in the heart. Cannabis does increase your heart rate up to 25 beats per minute, or up to 35% over controls, and this effect can last for many hours. So from a physiologic standpoint, if there's underlying coronary artery disease, this could lead to a mismatch of oxygen supply and demand and possible ischemia. Here's a picture of the study that was performed. At the bottom line there, there's the circles that essentially is placebo. Their heart rate hovered around 70 beats a minute after 4 hours. And then the square is the highest the highest dose of THC. And as you can see that there was a jump in the heart rates up to almost about 95 to almost 100 at a 90-minute time frame. It also can cause orthostatic hypotension. So patients who do have these underlying heart conditions can be it can be problematic. And so the conversation that you can have with your patient is, especially if they have a history of heart disease, you can explain to them that it has been known to increase the heart rate, which could be problematic with your history of heart disease. And if they are on a beta blockade medication that's trying to decrease the heart rate, that could cause some problems. There is a phenomenon or a syndrome called cannabis hyperemesis syndrome. Not all patients get it, but usually it occurs after a long, prolonged use of cannabis. It's similar but distinct from cyclic vomiting syndrome in terms of if one was to abstain from cannabis, this syndrome typically goes away. Now, usually they have multiple emergency room admissions over the years. They present with intractable nausea, vomiting, abdominal pain, and typically it's a diagnosis of exclusion. But abstinence can lead to an 86% cure rate from cannabis. So this is kind of the interplay between dronabinol, which is one of the cannabinoids that can assist with chemotherapy induced nausea and vomiting, whereas cannabis can increase the risk of hyperemesis. And this is thought to be a toxic buildup of cannabinoids within the gut tissue, and that leads to a potent downregulation in gut motility. There is an association with taking long hot baths. Patients will typically comment that that taking long hot baths will relieve their nausea and vomiting. So the conversation points here for your patients is cannabis is no longer a generally accepted treatment for chemotherapy-induced nausea. There is a FDA medication that is available, and then prolonged cannabis use can actually increase your disposition for intractable nausea and vomiting, and this can be very debilitating to the point where they seek emergency room care. If patients are driving or operating heavy machinery, cannabis, even at low doses, can affect their cognitive and psychomotor abilities required for driving. These effects may not actually be aware to the patient, and especially if they combine cannabis with alcohol. Patients typically will not be aware of their decrease in their psychomotor ability. The combination of cannabis and alcohol is a little bit of like a summative effect in terms of that the impairment of their ability to drive would occur at doses, even at low alcohol doses, low cannabis doses. Here, our conversation point is, although this is still being studied and there's not completely agreement for patients using marijuana, I suggest you do not drive for your own safety and those who might be injured if you are an impaired driver. Low levels of alcohol and THC can combine to lead to significant but unappreciated impairment that may injure you or innocent people. And so I think using this to in a way that we approach alcohol, that using cannabis can be dangerous, especially if they're involved in a very complex task such as driving. With regards to cannabis and memory, THC, the main psychoactive substance, does reduce hippocampal neuron activation. This is below the level that's needed to trigger memory formation. We see this especially within adolescents and patients who use cannabis for a long period of time, that regular THC users, regular cannabis users, have a smaller hippocampus by volume and have poor memory. Now, this was looked at in terms of a study that the use of 4 joints or more per week resulted in a decrease in mental test performance, especially patients who smoked regularly for a decade. Long-term marijuana users were impaired approximately 70% of the time on decision makers. And this was compared to 55% of the time with short-term users and 8% of the time for non-users. If there is a period of abstinence, there is a chance that decision-making ability can improve. But we are particularly concerned about the cognitive impairment for patients who use cannabis for an extended period of time. Our conversation point here with our patient is, if you are concerned about your memory or decision-making ability, you may want to reconsider marijuana. So who should not use marijuana? And this is just a summary of the possible side effects of cannabis or marijuana use. They have a history of a substance use disorder. A lot of times the cannabis interacts with the substance and can, increase the effect of the substance. We didn't really talk about this a whole lot, but there is an association between cannabis use and the development of schizophrenia. And so they have a history of psychiatric disorder. This is a patient that we would not recommend to use marijuana. They have a history of cardiovascular disease, coronary artery disease, with that increase in the heart rate. It a lot of times can last for even upwards of 4 hours after use. This could lead to negative effects from a cardiovascular perspective. They have a history of dementia or other cognitive disorder that we're concerned about them, their cognitive impairment or their ability to function or make decisions. We would not recommend those patients use marijuana. Anyone really worried about maintaining good brain function should not use, and this is particularly focused on patients who are at a young age and who still have a developing brain. And then anyone who drives or operates machinery should not use marijuana, again, due to the impairment that a lot of times they may not realize. So in that case, I'm going to stop my screen and take it back to Dr. Weiner.
I'm here. I'm just trying to get the slides started.
And while Dr. Weiner is putting together his slide presentation, I'd like to remind all of the participants, if you have questions, please feel free to put them in the chat box. And after the presentations have concluded, we will be more than happy to take your questions. Thank you.
Moving through this, hold on. All right, so for those, I think that this particular slide is one of the more important ones to pay attention to. And all in general, there are 2 points, there's to make in this talk. One is that there are a lot of reasons and things that we can tell patients to increase their level of concern regarding using cannabis. And the other is just to have the open conversations, which we're going to talk about in a moment. However, you might say, well, Dr. Weiner, Dr. Sullivan, you didn't tell us when marijuana was good to use, or for what medical condition is it good to use? And the answer is right. We don't know. There isn't nothing. There's nothing really good that we know about. There is, someone will probably bring up CBD and its connection to a very rare seizure disorder in children, but that is not something that's going to come up in the average conversation, I think, with patients. Most patients are not going to use anyway a CBD pure substance. So just go back to our case. So what happened to that guy? What happened to the guy whose pain was getting worse? And, I told him he should stop using cannabis, and he couldn't stop using it. Then he finally told me that he was a grower and a distributor. And basically, I explained to him that I was pleased that he was open to talk to me about. We developed a relationship where he was honest and open about that part of his life. I told him that from a medical standpoint, it appeared to me that cannabis was making things worse, and that I was uncomfortable prescribing a controlled substance, the buprenorphine pain medication, while he was on cannabis, and that I had asked him to make a decision and help me work with him to make a decision. And he decided he wanted to be withdrawn from buprenorphine, and I helped him. And he wanted to stay on cannabis. And I didn't see him for about 3 months. Finally, he came back and said, I've reassessed things. I'm stopping cannabis. I want to go back on the medication you were prescribing because my quality of life was much better. He did so, and things improved. He's been cannabis free now. To date, this slide's been about 4 years now that he hasn't had any cannabis, and he's doing really well. And he learned something. I think it's important for us as healthcare providers to remember, as part of the Hippocratic Oath here, that we will prescribe regimens for the good of the patients according to my ability and my judgment, and never to do harm. So that means it would be hard for us to endorse cannabis use with our patients. I think what we can get, if you get to the part of the conversation where the patient is telling you, Doc, I'm going to be using cannabis, is to say, well, I cannot tell you that that's safe. I cannot tell you it's effective for any condition. And that if you're going to use it, I'm here to help you, but you're using it at your own risk. And it's important to document those statements as well. The appropriate ends concept is that a doctor will do what is best for the patient rather than what is best for the physician. This may not seem like something that would ever happen in real life, but I will tell you that even currently, when there's a tremendous amount of attention on reducing the amount of opiates prescribed, I have had patients tell me that their primary care doctors have said, why don't you use cannabis so I can stop writing for this Norco or this hydrocodone, this pain medication. And when I think about that, it's nuts, because it's a physician telling a patient to use a non-FDA tested a substance that has all kinds of risks to one that is actually known to be safe when used appropriately. Not saying that opiates are great. We have there are problems with those as well, which are a topic for another talk. But really, that seemed to me like the doctor was taking care of himself or herself to get them off their list of prescribers. prescribing patients. So in summary, conversations with your patients about cannabis should be expected. The conversations should be encouraged. You should want to talk to them, to learn more about your patients and why they're using cannabis, and share with them what you know. Relax and use the conversations to learn about your patients' frustrations, expectations, their fears, dreams, etc. Take the time to educate. You now know a little. You know a lot more than most because you were at this lecture. Please use that to educate your patients. Remember to be compassionate. It goes a long way. That's what patients really appreciate. And even though patients will bring their own agenda to the visit, you always treat patients with respect, understanding, and dignity in those conversations. So thank you for listening. This is how to contact me. You also get a hold of Dr. Sullivan at the same numbers. And now I am open for questions.
So Dr. Weiner, we have one question from Robert Sane. And that question is, if 9.4% of adolescents can become addicted, are you saying that the other 90% are spared from the effects of marijuana use, and that 90% never become dependent of marijuana?
So no, those are a couple problems with the statements. The 9% is one problem is it's based on the older potency of cannabis. So, but what that showed is that of the people who were cannabis users in that study realm, 9% became dependent, meaning they were unable to stop using, and such to the point that they needed addiction assistance to help them. That does not mean that the other 90%, 91%, who may be using cannabis are without any adverse effect. They could be primed for other addictions, which would not be included in that 9%, and they could have all kinds of problems with brain development, cognitive function that can go along with using cannabinoids. Unfortunately, with this very high potency of cannabis that is available now, we are essentially conducting a very large experiment on our children to see what's going to happen in about 5 to 10 years, and it's troubling. So hopefully that answered your question.
Yeah, it does, and I think I want to make sure that I read the last part, which really isn't a question, but really it's actually sort of a rhetorical question, where Mr. Sane says that as a child and adolescent psychiatrist, Dr. Sane says that the kids continue to tell me that there are no deficits related to marijuana, even the smart ones. I can't find a good reason not to advocate against the use of marijuana.
Okay, well, hopefully you've got some references now where you can advocate toward future problems with cognitive function, and there's definite issues with the potential development of psychiatric illness with the use of cannabis over time. So I think there are reasons to advocate against it. If you're seeing a patient who is, I'm just thinking of what patients are coming to the child psychologist or psychiatrist, they obviously have some pre-existing problem with depression, anxiety, trouble fitting in. For that reason alone, I would recommend a trial of remaining cannabis free and seeing how things improve, because these things are associated with those outcomes. Of course, that becomes the difficulty, as we all know, and why we're having this talk, helping those who are not used to having the discussion have more meaningful discussions with patients.
And another question regarding the cannabinoid buildup in the gut, how does this resolve?
So for the cannabis hyperemesis syndrome, the theory is that the cannabinoids deposit in the fat lining of the gut, and they will continue to remain there as long as the person's using. When they stop using, they are broken down very, very slowly and dissipate out of the fat layer very, very slowly Therefore, it takes sometimes 6 to 9 months before people return to where they have no nausea at all. Sometimes it could be even longer. So it's just the body clearing the cannabinoids, which because of the chemical properties of cannabinoids can take weeks or months.
Thank you, Dr. Weiner, for answering that question. Once again, we still have a few minutes left. If you have any questions for either Dr. Weiner or Dr. Sullivan, please feel free to place them in the chat box.
Do you have any warnings during COVID-19 for cannabis users with comorbidity and additional public health concerns?
That's a very, very interesting question. I mean, I can tell you that due to when you're in a period of increased stress, people who have a predisposition to substance use disorder will use more substances and more prevalently when they're off work or out of their routine. We see people using a lot more alcohol, opioids, cannabis, and ending up in the hospital because of this. You know, I mean, hearing what patients go through to get illicit substances is astounding. And even though they are very caring about their own health and the risks of social interaction, you know, they're going out of their way to make sure that they obtain the substances they need. There's no, you know, patients who have pre-existing conditions, if you're referring to those who have underlying heart disease or lung disease, who are more likely to have problems with COVID, you know, I can tell you cannabis isn't going to help. I wouldn't recommend it as a treatment, but just to keep in mind that in this setting of increased stress and changes, if you are developing or you know someone who's developing a substance use disorder, it's a good time to find them some help.
Yeah. So I actually have a question for Dr. Sullivan. Well, Dr. Sullivan, earlier in your presentation, there was a slide saying that Emperor Shenning used cannabis to treat autoimmune diseases like gout. My question is there anything in recorded history that indicated that it worked? I know this is kind of a weird question, but I'm just trying to figure out if you had someone like that using it, did that impact other people and what effect that's had on history?
Yeah, I mean, I think it's a plant that's been around for a long period of time, and I think it is hard to compare, you know, the marijuana that's available today versus you know, that was available at that time. I think there's some opportunities, you know, for therapeutic benefit regarding the actual, you know, the plant and the cannabinoids that are within the plant. I think it's just there's the one big issue has been even the study that I referenced. The improvement in pain quality was a very controlled environment, whereas I find it, you know, hard to really recommend anything that I don't know what exactly is in that. So, for example, the Emperor may have used, you know, 0.5% THC, and then, you know, the 30-year-old that I had with gout, you know, that I saw to my clinic yesterday, you know, maybe the cannabis that's available to him has 15% THC. So, yeah, so I think it's a very difficult question just in terms of the variability.
Yeah, I'll just add too that, you know, back then they weren't doing placebo-controlled double-blinded studies when they would write something, you know, in the papyrus. So you got one person's opinion, but also if you think back then, there were really no other substances. So maybe a small pain relieving effect was significant. compared to nothing. When in some studies, the pain relieving effect of using cannabinoids or cannabis is equivalent to 2 extra strength Tylenol. So there is a pain relieving effect. It's not tremendous, but if you don't have Tylenol, it makes sense. If you have Tylenol, it doesn't make sense to use cannabis for your pain.
Gotcha. So it looks like, oh, is that Gabrielle? Are you gonna? That's me. That's me talking.
I think we can
Yeah,
maybe take one last question and
okay.
wrap this up. Looks like folks are looking for some Washtenaw specific statistics on cannabis usage and also just general information about cannabis being a gateway drug to potential other addictive drugs or the like. Any thoughts?
I know that the health department keeps very close tabs on and publishes information regarding opiate use disorder. I'm not aware of anything recent regarding the cannabis use disorder or cannabis use. But if it's like the rest of the country, what we're seeing is a significant increase in use, primarily in adolescents, starting at age 10. And it is associated directly with a perception that cannabis is safe. And when you look at the country as a whole, the changes occur as states legalize cannabis for medical use. This, when you look back 10 years, and that suddenly became this rapid change of perception in younger people that cannabis was safe, which of course then led to an increase in use. So we're seeing a significant increase in use over time. And now that we're looking at the recreational, it's legal for recreational use, we're seeing even a greater increase in use in people 10 and above.
I did want to just really quickly follow up. It looks like someone asked for getting information about specific cases, and I have placed the answer to that in the chat box. Let me just make sure that I can get it so that everyone can see it. There we go. And so there's a website that will give everyone the information, that give everyone specific
Thank you.
cases, yep, in the box there. So yes, and so that's going to end today's session. We want to thank Dr. Sullivan and Dr. Weiner for giving such great information. I actually learned a lot. I have on the last 2 calls. So I just want to, on behalf of everyone involved, thank you two for agreeing to speak with us and provide all of this great information. I did want to let everyone know on the call that our 3rd webinar in this series will be occurring next Tuesday, so a week from today, beginning at 12 p.m., where the topic will be Legalize Cannabis in Michigan, a medical, business, and scientific perspective, where the featured speaker will be attorney Barton Morris. So we hopefully will be able to have those folks join in for this, and that'll end today's webinar, unless Dr. Sullivan or Dr. Weiner, you have any closing thoughts?
None. Thank you for having us.
Absolutely, and thank you. Any other fellow panelists, do you all have any closing thoughts before we sign off?
Thank you very much, everyone. Thank you, Dr. Weiner and Dr. Sullivan. If you're looking for recordings of this session or our past sessions, they're on the Washtenaw County Health Department Facebook page. Signups for next week's webinar are on the site as well. Thank you, and have a great rest of your week.
Thank you. Bye-bye.
Thanks.